wanted to really start from the beginning in terms of who do we activate code stroke, telestroke on, and having coordinated protocols. And so the requirements for a telestroke center is, again, coordinated care protocols with identified roles and responsibilities, rapid recognition of stroke symptoms, early activation of the code stroke system, both from a 911 call perspective to what you activate here in the hospital at Rutherford, rapid diagnostics interpretation of both your CT imaging and your labs, activation and rapid response from the telestroke provider, the RN and MD presence in the room during a telestroke assessment, and expedient administration of fibrinolytics in those patients that are deemed appropriate. Ongoing monitoring and assessment and good handoff communication, whether you're handing the patient off to a transport team or transporting the patient to an inpatient unit here at Rutherford. Just a few reminders about acute stroke. Every year, nearly 800,000 people in the United States experience a closed vessel stroke, meaning that the blood vessel itself has been occluded by a clot or fatty plaque, and there's no blood flow to that part of the brain. Just as a reminder, again, there are two fundamental categories of stroke. The hemorrhage or bleeding stroke is when you have an intracerebral hemorrhage or a subarachnoid hemorrhage, perhaps from an aneurysmal rupture. But the more common type is ischemic, and again, as the cartoon schematic shows, that is a clot that is occluding that blood vessel either from ruptured plaque or a clot that has traveled perhaps from the heart with atrial fibrillation, cardioembolic source. And that blockage of blood flow is really the beginnings of the cascade of an acute ischemic stroke. The progression can be rapid and it can march out over time. So really, when you have an acute ischemic stroke and you have blockage of that blood flow, just think of that blood flow damming up, and there is no blood flow getting through to the backside of that part of the brain. What's keeping that brain alive is actually collateral circulation, or if we can open up that artery and reperfuse that territory. So in the initial phases of it, and again on the schematic you can see on the slides, is that really zone, that little tight reddened area is the core of the stroke. It's where the infarction is occurring, and that begins immediately from the time the blood flow stops, brain cells start to die, the infarction is beginning, The zone around that area of infarction is referred to as the penumbra. The penumbra is a term that means shade or shadow, and so there you have an infarction and you have an area around this in the brain that is at risk. The sooner we can reperfuse this and give blood flow back to that area, the better the patient will be. So statistics show us, literature points to us that for every 15 minutes we can reduce the treatment time, we have more patients walking out of the hospital functionally able to go home. So again, back to the basics, how do you spot a stroke? If you don't recognize it as a stroke, you're not going to activate the system, and if you don't activate the system, they won't get treated. So again, we use the FAST acronym: face, arm, speech, and time. In studies, this is shown to identify about 85% of all strokes can be found with at least one area of that assessment. So you teach it to the community, you teach it to EMS, you teach it to your own providers. The patient has typically unilateral facial droop or an arm drift, leg weakness, speech difficulty, and it's time to call 911. Again, in the hospital, when that patient presents to triage, you're going to do that really quick, rapid neuroassessment, looking again for the signs of a stroke. Other more common signs of a stroke that are outside of FAST may be sudden numbness or weakness of the face, arm, or leg. It's usually unilateral or on one side of the body. Sudden confusion or speech impairment, impairment in one or both eyes, sudden trouble walking, dizziness or loss of balance or coordination, and very typically these are the patients that will fall out, because a patient comes in who suddenly became very dizzy. As ER nurses, we're thinking vertigo. We're thinking anything but stroke, but I challenge you to keep that in your differential diagnosis. If someone suddenly becomes confused and they're not able to get out what they want to say, they may be confused, but they may be having a stroke. So remember, sudden onset. Severe headache with no known cause we don't see as typically with ischemic strokes. These are more of your hemorrhagic strokes, but they're both types of strokes. I did want to go over some of the time windows that seem to get confusing because we have a lot of hours that we throw out at people. So activate a code stroke for any patient presenting with stroke symptoms with a last time known normal to be less than 5 hours. Alteplase is approved by the FDA. That's IV TPA that we give for acute ischemic stroke. FDA approval is within 3 hours from the time of onset. Alteplase IV off-label, which is not supported by the FDA but is supported by the literature, you're able to go out to 4.5 hours for select patients. But the bottom line is that we really need to treat as soon as possible. Getting the wheels moving as soon as that patient hits the emergency room doors in order to get down to what we call target stroke. The American Stroke Association and the Joint Commission now support these as the parameters that we need to aim for. And it's door to needle time, which is basically from the time they hit your emergency department door to the time you start that IV TPA. We want that to be less than 60 minutes, 75% of the time. Door to needle time of less than 45 minutes, 50% of the time. So the Joint Commission, American Stroke, neurology, they're all pushing for us to actually really work on our processes and hone in to where we have really short door to needle times. Because again, for every 15 minutes we can shave off of that, our patients are going to have better outcomes. Again, this slide is really, again, speaking to the don't delay, what you should do when you've activated a code stroke. Again, onset less than 5 hours with a measurable neurologic deficit. You need to obtain a blood pressure. Be prepared to administer IV medication to lower the blood pressure if the blood pressure is greater than 185/110. Obtain a patient's weight. IV Alteplase TPA is weight-based, and so it's important to get an accurate weight for your patient. Initiate 2 large bore IVs, 18 gauge or larger, with at least 1 in the anacube. We are asking our hospitals, our telestroke hospitals, to do a CT angiogram as part of your code stroke CT protocol. With that CT angio, you have to infuse contrast, and it's given under an infusion device pump, and so you really need to have that larger bore IV in order to give that contrast. You need to draw stat labs. We need a glucose, either point of care or a serum glucose, chemistry profile, magnesium, CBC, and PT-INR if applicable. So if your patient is known to be on warfarin, we need to know the INR. An APTT if the patient has been on Lovenox or heparin. Troponin is important, and also to do an EKG. Stat imaging, again, as I mentioned, we're looking for a code stroke CT non-contrast to rule out hemorrhage with a CT angio of the brain through the aortic arch unless contraindicated. The CT angio should not delay IV Alteplase initiation. So the goal is to really get them to CT, rule out hemorrhage on that CT without contrast, and get a telestroke consultation. So really it's sort of simultaneous things have to be going on. So you get a patient in, if EMS is called pre-notifying, you can go ahead and start your pre-registration process. So as soon as that patient hits the doors, you can be activating your code stroke, going to CT, drawing blood for labs, calling Mission Direct so that the telestroke provider will have time to get on the laptop and join you in the room. These are just some snapshots of a provider using the technology. Cameras and microphones in both places allow the doctor, the technician, and the patient to interact. And it's as if they were all in the same room. So really think about this is that the mission neurologist who joined you in the room as a telestroke provider, they're on your medical staff. They're credentialed to be at Rutherford Regional, and they will join you in the room just as if you had another specialist coming into the room. The caveat, of course, is that you're going to have to help assist with that because the robot, the device that he's beaming in on may not have, it doesn't have arms, he may not have the capabilities of moving that cart around, so you need to always have a staff present in the room when the telestroke doctor beams in. But the telehealth robot allows patients who come to Rutherford Regional exhibiting stroke signs to be seen by a mission health neurologist without having to leave Rutherford County. It's pretty cool technology when you think about it. What are we asking you as the ED nurse to do? The telestroke RN role is, again, have the telestroke cart at the patient's bedside. If you're activating a code stroke, move that cart in there. Do not leave the cart unattended. Assist the provider with the neurologic exam and information gathering, and the video will go over that. Report to the telestroke provider any pertinent history, recent vital signs, and lab results. Have the alteplase in the room and be prepared to mix and administer it. And finally, we need for you to document your information in the Stroke Respond, and that's our information portal so that our providers can actually see that there was a patient being seen at Rutherford because we're not currently on the same EMR system. Again, this kind of goes over your target stroke criteria and your goals, and this algorithm will also be in your training packets, and this sort of maps out exactly what I've gone over in terms of the time windows and when things need to occur. We will also be going over a video with you about how to mix alteplase for acute ischemic stroke. Again, it's weight-based. The max dose is 90 milligrams. It comes in a 100 milligram vial, meaning that you are going to have to waste at least 10 milligrams out of that vial. But because it's weight-based, you may have to waste more than that. The bolus is 10% of the total dose to be given based on their weight over 1 minute, and the infusion is 90% given over 1 hour. Key points in giving alteplase for acute stroke patients: it may be administered peripherally, IO, or centrally. You waste any additional medication that is not the dose. The IV pump and drug library for alteplase infusion should be used, and the medication requires independent double check, and remember to document. Accurate weight is needed, and once it's reconstituted, it's 1 milligram per milliliter. A lot to get done in less than 60 minutes, and that's why it goes back to the very beginning of having a coordinated plan of care. And I'll stop here, and we will answer any questions, and we can also then go into the video that shows about how to prepare alteplase. Thank you.